What you see on the screen is a piece of parchment obtained from the Manual of Medicine and Surgery that was published by the British Dr. John Dean in the year 1400. As you can see, this anatomical sheet shows a human body cut sagittally from cranial to caudal with the aim of exposing the internal organs and some of their diseases. Thus, we can see that the heart has a hypertrophic aspect, and the author writes about it in the accompanying paragraphs. This is, without a doubt, one of the first descriptions made about one of the most frequent problems in modern cardiology, myocardial hypertrophy. As you see, painting was the only cardiac image technique available in ancient times, and in spite of how much the world has changed since, we, present cardiologists, keep drawing hearts. Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. As you know, in this channel we try to represent with drawings the complex and fascinating world of the cardiology with the objective to ease the process of academic formation. However, we are not the first to do it, because the heart has been the object of study and devotion since the beginning of time. The visual perception of its beats and its unremovable connection with emotions have motivated the interest of an uncountable amount of people to unravel its mysteries and immortalize in an image its functioning. This is why these are 5 images: hypertrophic cardiomyopathy. Number 1. Hypertrophic cardiomyopathy is a genetic disease that affects the heart muscle and is generally caused by a mutation in the genes that encode sarcomeric proteins, presenting an autosomal dominant inheritance pattern, a heterogeneous clinical expression, and a very diverse natural history. As you know, the diagnosis of this entity is usually made by echocardiography. Thus, the most characteristic finding is usually disproportionate myocardial hypertrophy of the left ventricle in the absence of other cardiac or systemic disease that justifies it. Although in most cases the hypertrophy is septal and asymmetric, diffuse concentric hypertrophy may also appear, or in specific areas, such as the apex of the left ventricle. Sometimes the septum may show a ground glass appearance, which is usually related to myocardial hypertrophy. On the other hand, with regard to the left chambers, we can say that the ventricle is usually small in the initial stages, although it may end up dilating in the final stages of the disease, while the atrium is usually dilated from the beginning, as a consequence of the diastolic dysfunction that ventricular rigidity generates. Because, precisely, diastolic dysfunction is one of the most frequent problems of myocardial hypertrophy. Thus, most patients tend to have relaxation abnormalities with pathological transmitral flow. But what about left ventricular systolic function? Well, very simple. Although the ejection fraction is usually preserved, the global longitudinal strain is usually decreased at the expense of the most hypertrophied areas with extensive fibrosis, which can become a prognostic factor for heart failure or sudden death. However, in particular cases of apical hypertrophy, the global longitudinal strain is usually preserved, and regionally it may be normal, decreased, or paradoxically everted or positive, which means that there is a systolic elongation or apical dyskinesia. Last but not least, when septal hypertrophy is severe, a functional obstruction of the left ventricle outflow tract can occur, accelerating blood flow, generating intraventricular pressure gradients, and a systolic movement of the anterior leaflet of the mitral valve that secondarily triggers mitral regurgitation. Number 2. The electrocardiogram is abnormal in more than 90% of patients with hypertrophic cardiomyopathy. Its findings are determined by the extent of hypertrophy, the presence of fibrosis, and the appearance of intraventricular conduction disorders. Thus, the most frequent alterations are signs of left ventricular hypertrophy with increased voltages. It is weakly correlated with the magnitude of hypertrophy on echocardiography. alterations in ventricular repolarization, frequently expressed as inverted T waves in lateral precordial leads, pathological deep and narrow Q waves in inferior and lateral leads, reflecting severe septal hypertrophy, complete bundle branch block or left ventricular conduction alteration due to fibrosis and myofibrillar disorganization, and finally dilation of the left atrium. However, apical hypertrophic cardiomyopathy deserves special attention as it tends to produce particular electrocardiographic abnormalities, for example, early high R waves in precordial leads and deep negative T waves in anterior leads. Number 3. Cardiac magnetic resonance can accurately characterize the presence and distribution of ventricular hypertrophy. In addition, it allows a better estimate of ventricular thickness in all segments, and a more complete study can be carried out in those patients with a poor echocardiographic window. On the other hand, the detection of late enhancement with the use of gadolinium allows to identify areas of myocardial fibrosis. Its location is generally at the level of the left ventricle with a classic pattern of intramyocardial patching at the level of the areas of greatest hypertrophy and in the areas close to the junction with the wall of the right ventricle. It is present in advanced stages and is related to ventricular arrhythmias and sudden death. Number 4. Chest pain is a common symptom in patients with hypertrophic cardiomyopathy. The mechanism that has been associated with this symptom is microvascular ischemia. However, it is necessary to rule out atherosclerosis of the epicardial coronary arteries. Furthermore, intramyocardial coronary tracts are not uncommon in patients with hypertrophic cardiomyopathy and may be the cause of pain. For these reasons, and taking into account the high negative predictive value of cardiac CT, the coronary scan could be considered the technique of choice when ruling out coronary disease in patients with hypertrophic cardiomyopathy. Number 5. As you know, unlike CT, cardiac catheterization allows us to perform invasive coronary angiography. In this way, we can definitely rule out coronary disease. However, the usefulness of cardiac catheterization is not limited only to angiography, since catheters can help us to carry out an intracavitary hemodynamic study. Although it is true that invasive hemodynamic study is not necessary for the diagnosis of hypertrophic cardiomyopathy, it can be useful in patients with complex echocardiographic studies. Thus, the typical hemodynamic characteristics are the increase in end diastolic pressures of the left ventricle and the existence of a pressure gradient at the mid-ventricular level. Finally, a non-negligible percentage of patients have severe left ventricular outflow tract obstruction that is refractory to drug treatment, and although cardiac surgery is usually the solution, some patients may not be suitable. For these reasons, alcohol septal ablation is a very useful therapeutic alternative in these cases. But what is a septal ablation? Very simple. This procedure consists of the selective catheterization of the first septal artery with the aim of injecting alcohol into this vessel and thus producing an infarct located at the level of the basal septum. This reduces the dynamic obstruction of the outflow tract and, as you can imagine, it also reduces the midventricular gradients and mitral regurgitation. As you can see, cardiac imaging can be useful in the study of hypertrophic cardiomyopathy, and although we would like to go deeper into this topic, it is no longer possible because our time is up. It has been all for today at Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!